Hey everyone, good morning. This is Sonia with Mettle Health. We are so lucky to have a guest facilitator today while BJ is traveling in Australia. This is Claritza Rios. She is a career educator and has worked across several healthcare settings and specialties in an effort to improve the quality of life of patients along all stages of chronic illness. She's also built palliative care programs and is a passionate advocate for palliative care education. And in recent years, she's focused her efforts on ways of increasing access to palliative care to high-risk populations. So we are so happy to have Claritza to help us walk through the topic of active dying in the final days of life. And Claritza, I'm going to ask you to just go to the next slide really quickly so I can go through logistics of asking questions. So if you've done this with us before, you know this part, but for anyone who is new to these talks, we have two ways that you can ask a question. Claritza will go through a little bit of just basics on active dying and end of life with some slides. And then once she's done with that, we'll go to questions. So you can either raise your hand up there at the top and we will unmute you and you can ask the question out loud and chat with the group, or if you would prefer to not say something out loud or remain anonymous, you can type your question into the question area and we will read it aloud for you and get it answered. So two ways here: raise your hand, ask it verbally, or you can just type it in down at the bottom and we will address it. And the other thing to note here is that sometimes we are not able to get to all the questions within the hour. So if that's the case, please do not worry. We will do a second little recording here where we will answer those questions and we'll post those on YouTube as well. Okay, that's it. Thanks everyone. Thanks, Claritza.
Thank you. Thanks for that lovely intro. I'm so happy to be sharing this time with all of you today. A little bit about me. I have two very barky dogs, so I apologize ahead of time. They get really excited. So heads up on that. And just let's jump right in. As Sonia said, I'm really passionate about palliative care and this kind of care and advocacy. As a brand new healer, I saw firsthand the effects that and the toll that chronic illness took on patients and loved ones and their families. And my mentors really inculcated in me the importance of seeing chronic illness, death, dying through the eyes of a whole person. And so that's the work, that's what brought me to the work and what I've spent the past few years developing and currently really leveraging technology to bring care to marginalized populations as of late. And so this conversation is really important. And conversations like this, I'm so glad that you're all here because conversations like this are really important. They really create a space for us to start having more conversations about seeing ourselves and our loved ones within chronic illness as whole people. And that is also true in dying as well. And so I am going to be speaking to you all today. I'll introduce a lot of terms and timelines, but first we should talk about a disclaimer. And that is that just like every birth is different, so is every death. And so I want you to use the information that I'm sharing with you as guideposts and again, a guide, but keep in mind that you have to keep an open mind because every death is unique. And so let's go ahead and start by really defining the stages of death in the context of chronic illness and aging. And they are as follows. You have pre-active death versus active death. Pre-active death is defined as a time 2 to 3 weeks before the day of death. And active death, the duration of 2 to 3 days before the day of death. So let's touch a little bit about what you can observe during pre-active death. What you may notice is that the dying person may have changes in their sleep. They may sleep a little bit more, spend more time in bed and be more tired. You may also notice that their appetite may not be what it was, and you may be noticing that the appetite is decreasing, but there may be a sharp decline in what they're eating. There may be some changes in their mood. And it's really important, especially as caregivers, to know that this is totally natural. And while this is a really emotional time and one that we take very seriously as caregivers, can't really blame yourselves because they're not eating because the food wasn't appetizing enough, or you said the wrong thing and made your loved one upset. This is all very natural and not related to something you've done. Another thing that we see often in the pre-active dying phase is patients know what's happening to their bodies, and they understand that death is near. And so people may want to take care of unfinished business and have a need for closure. And often family members and patients will ask about a request for a meeting or a visit from someone, usually somebody that is estranged to them, so that they can have this closure. And so the question for me is usually, hey doc, when's a good time to have this conversation? And so my answer is always, as long as all parties are consenting, as soon as possible. The longer we wait, the more we risk the dying person's ability to have attention, to have the stamina to engage in conversation. And so again, when possible, as soon as you can. I also really encourage that the other party be the one that travel. Traveling in the pre-active or active phase is not really recommended. And as someone who is in tech now and post-COVID, leveraging technology where you can is a really great alternative. If COVID taught us anything, is that we can still communicate pretty well with each other by using video chat. And so, like we're doing here. And so feel free to use that as a tool, as it is really, can be really helpful. Moving on to active death. This is the stage 2 to 3 days usually before the end of life, before the day of death. What do you notice then? You can start to notice that the breathing patterns of the patient change. The blood pressure starts to come down, and what that will manifest physically is you'll notice sometimes changes in the skin color. You may actually note blood or hyperpigmentation, a higher color in the areas where the body's dependent, where the body touches the bed. You may notice that the hands and the feet can be a little cold. And you may also notice some noisy breathing, which is usually related to our cough and our swallowing reflexes not being as strong as we are dying. And so secretions are in the airway and we can hear that. Unfortunately, the name that is often used is not a super fun one, death rattle, but it really just speaks to noisy breathing. I cannot mention this enough, and I mentioned it in the pre-active phase, that this is completely normal, and it's never a result of something that you're doing wrong or the medication that you gave. It is part of the dying process. And what we know from our observations and the data available to us is that these manifestations don't really bother the patient. They bother us more. Much like a baby will instinctually suck their thumb or move in a certain way as they're born, the same thing in the dying process. This is very normal. We always encourage, however, that if you're not sure or if your gut is telling you something doesn't feel right, to really let the hospice team, the medical doctor taking care of the patient, whoever is providing the care from the medical perspective, ask them questions, let them know, especially if your gut is telling you something. We encourage questions. Remember that this is about your care as well as the patient. It's a package deal. I'll talk a little bit about sitting vigil with a dying person. First, sitting vigil is a privilege and it's some heavy stuff. And so let's call it what it is. It can be intense while at the same time an amazing privilege. The first thing that I would speak to is the importance of having a plan. Because it is heavy and because it is a life-altering event, who's going to be there? Are we taking shifts? how many people are in our community that we can pull in to help in this process? And importantly, what does the dying person want? I think many people want to be surrounded by loved ones and their community in the dying process. But some feel that they want to be remembered for their surfing or their gregarious interactions at dinner parties. And maybe this event isn't the one that they want to be remembered in. And so they may want to have a much tighter circle. And so this is an important plan to discuss ahead. I think another really important thing is also what is feasible given your community, given your finances, what can be done. These things should be discussed ahead of time. Another thing that comes up is a lot is, what do I do? What are some of the things that are expected? What are some of the things that are recommended? And so I have a few things that I have listed here, and please, as we go to questions, bring up more thoughts, ideas, etc. One of the things that folks can do when they're sitting vigil is really monitor the symptoms. There may be pain, discomfort at end of life. And as caregivers, we know the dying person better than anyone. And so if you're not sure, or if you notice a new symptom, it's really important to let the medical or hospice team know so that they can provide the right treatment for the person. And as caregivers, we're often called upon to give medications, and you're usually instructed on how to help support the symptoms. Another thing that you can really do is provide the physical comfort. And so simple things like hand holding, massage, if it's appropriate to your relationship with the person and their likes and dislikes, is a very helpful way of bonding, and also providing comfort. Things like mouth care. As we die, we tend to breathe more with our mouth, and therefore our oral care is important because we tend to get a little dry. And so swabbing the mouth, applying lip balm, these things, again, are practical, but also an opportunity for closeness with our loved one. And certainly you want to make sure that the bed is cozy and the pillows are right, with minimal movement of the patient, but you really want to check in on that physical comfort. Other things that you can do is clean the person. Sometimes at end of life, you can have fevers, you can sweat, and so gently washing the face, the neck, the arms can be an amazing opportunity to again, do something practical that can give the patient comfort, and also an opportunity for touch, massage, of course, if appropriate, for the relationship you have with the patient and what they like. Again, we don't encourage baths or showers, but just gentle touch and cleansing can be very helpful. Another really important thing that you can do while holding vigil is creating a peaceful environment. We really feel strongly that less external stimulus is better, because just so much is happening in the dying process that it takes a lot of energy to be aware. And so we want to be mindful of noise. We want to be mindful of lights. You want to always check in on the cues that the dying person is giving you. If you start playing music and their furrow relaxes, that's wonderful. And music usually tends to do that. We usually think of relaxing music, but some people are Wagner fans and would like to hear that kind of music at end of life. Obviously, follow the cues that the dying person is giving you, and trust that you know them. That is a really big takeaway that I want everybody to have, is this person best. And so if your gut is telling you something, follow it, and tap into those resources like the hospice team, your medical team, and ask questions. Another really important thing that you can do is just give the dying person and yourself space. Build in short breaks. It is really important for them because, again, there's so much stimulus coming at them and their body is declining and going through some stress. And so short breaks are good for them as well as good for you. I will share with you, and this comes up a lot, a phenomenon that I've noticed in my practice, and anyone here who's dealt with dying patients can speak to, and that is, so I've had the privilege of being in the presence of many deaths, and several times a family member, usually, or a loved one, somebody who has been holding vigil for hours, days even, will need a break. They're beat, they haven't even gone to the bathroom, they're that intensely holding vigil. And the patient's stable, a decision is made, I'm gonna go take a shower, I'm gonna go for a walk, I'm gonna go pick up the grandkids, I'm gonna go for a coffee. And I've personally witnessed that the minute this vigil holder steps out of the space, the dying person dies. And there's always the why does this happen? But this phenomenon says two things to me. Number one is that this can absolutely be a coincidence, 100% a total coincidence. And I am going to share with you my personal experience as a palliative care physician and as a woman. And that is that I feel often the dying person does this in a way to relieve suffering for that vigil holder. They don't want to burden them with being witness to the act of death. And so I see it as an act of love and a gift. But it can very well be a coincidence. The other thing that this tells me, and is really helpful as I support and advise families, is that it tells me that people are still aware, that while their bodies are in the dying process and are unable to express outwardly their awareness, they're still here. And this helps me advise people to, when you're sitting there, sing, talk to them, tell people you love them, because they probably can hear you, and say those things that are valuable and you want them to take with them. I want to now pivot a little bit and talk about hospice at the end of life. And so first, just want to go through some definitions. Hospice care is a philosophy of care. It really focuses on quality of life at end of life, relieving suffering, supporting the whole person. It is also an insurance benefit that terminally ill people can access when they are at end of life. Hospice can be provided anywhere, including the home, where folks, patients and families, loved ones, caregivers, the village, have access to a team of doctors, nurses, chaplains, social workers, volunteers, and are given medications and instructions on how to support their loved one as they transition to death. And while the hospice team is available 24/7, they're not omnipresent in the home in an effort to demedicalize the dying process, but they're available. And the amazing thing about hospice is that the team is there to support the dying person and their support system and treat the symptoms of not just the physical manifestations of dying, but also the existential, social, psychological manifestations and symptoms of dying, and not just of the dying person, but their village, their people. I want to talk a little bit about the actual event of death and the peri-mortem, the peri-death, around death time. If you're here, or if you're even thinking about death, for the most part, we envision, anticipate, play out the event in our heads and are really ready for it. It is so important, however, to keep in mind that the reaction you think you're going to have, and that your partner, your friends, the cousin, that your sibling's going to have at the time of the loved one's death may differ from that which you have planned or expect. And that often you, as the loved one and caregiver, may have something totally different in your emotions. And sometimes you can feel a little numb. Sometimes people say to me, I feel utter relief, and even a little embarrassed that some people are happy that death has occurred. And it's really important that everybody knows. And another big takeaway is that all of these things are normal. So sad, happy, angry, uh, shocked, even though you've been sitting vigil, all these things are very normal. And a really important thing is that not one of these emotions speaks more to the devotion, love, dedication, passion you had for this dead person than the other. They're all the same, and they're all important, and they all need to be experienced, and they may vary minute to minute, hour to hour. And so we often encourage making time to process that. And sitting with the body can be a great way of being in that space and to have that closure. And of course, we want to make sure that as we're sitting with the body or spending time, that it's all within the parameters of any religious timelines that you may have for burial, depending on your belief system. But for the most part, time can be made available for this to happen. It can impact closure. And in some cultures, it is highly encouraged because it really does allow people to process. A little bit about pronouncing of the death. If you are working with a hospice team, this will be done. Usually it involves an examination where we look for signs of death, and a time of death is called, as we say. Sometimes the primary care doctor can participate in that. And usually the funeral services, funeral home will be called. These usually is planned ahead, and the process is pretty straightforward. A phone call occurs, a time for pickup of the body to start the burial process is made, and it is pretty straightforward from the caregiver standpoint. I want to touch a little bit on the burials and options and opportunities. So just a few points here. The choice for how you will be buried or you will be memorialized is often influenced by your religious beliefs, your spiritual beliefs, and cost. This stuff can get really expensive. So obviously all these things will come into play. I believe strongly that having a conversation with a dying person is critical, obviously for planning and financial reasons, but also because it's an amazing opportunity to come together and bond and to start to memorialize the loved one. And so, and that legacy conversation can sort of begin before a death happens. Traditional burial and cremation we're more familiar with. Natural burials are more and more an option that is coming up and becoming available, even in the United States. And this one comes up when people feel like they want to have less of a carbon footprint as they are no longer alive. And this is becoming something that is more popular, and so much so that now you can just do a Google search for natural burial, and several websites will come up with cemeteries and funeral service companies that provide this kind of service. And one that I recently came across was naturaland.com. But I'm sure there are many opportunities out there. But again, I think that with all these things that we're discussing, it's really important to consider creating space for conversations where you can come together as a village, as a family, as a partnership, and to start the legacy and the memorialization of this loved one and the dying person. And with that, I will open it up to questions. And yeah, we have a question that we ask, which is, just to start the conversation, what is the biggest question about the end of life that you have? But I'll pass it over to Sonia to moderate.
Okay, great.
And I'll stop showing my screen.
Okay, perfect. Thanks, Claritza.
Yeah.
It looks like, let me see if we've got any hands up here. And if not, I know we have a question that was already sent in, so I can start with that. So someone sent in a question earlier and she said, I'm hoping you can touch on dementia in final days. I work inside a memory care unit and have journeyed with a handful of dementia residents during their death. I'm wondering how support for the family versus the person who is dying differs during the final days.
So I think that dementia is a tricky diagnosis, especially at end of life, because family members feel really strongly that they are unable to advocate for the dying person because they're unable to speak to their symptoms of what is that, if there's any discomfort. And so it's really important as caregivers to share with them that we're lucky to have data research to help us inform how we care for dementia patients and finding objective signs and symptoms of discomfort. And so in dementia units, hospice units, we're all trained on objective signs of discomfort. And so things like muscle tension, brow furrowing, the way that the person is holding themselves. We have scoring systems where we can really address discomfort. And so that is really helpful, but often we really encourage families to just go with their gut and share with us what they feel the person may be feeling. You know, mom, whenever she was in pain, when she broke her leg 50 years ago, she grinded her teeth. I'm noticing her grinding her teeth. Why don't we go and evaluate that wonderful thing to help the team caring for her address her symptoms? We're very careful with medications. We always give just enough to relieve suffering. And so really helpful to have these conversations. Another really important thing is that families sometimes feel, well, mom has dementia, so I don't know that she's going to hear that I love her, that I am going to miss her. And as I mentioned earlier, people still have awareness, and so they may not be able to cognitively understand the words, but they know how you're making them feel. And so I often feel it's really important to encourage them to continue conversation, to continue touch, to continue to be present, even if we think mom hadn't spoken to me in a while. Do what you did before, which is just be in her presence and show her that you love her deeply.
Okay, great. We've got a few other questions that have come in here. So the first one is, my question is about the use of oxygen at the end of life. And she said even hospice nurses apply it when the quote unquote O2 is low.
Yeah, that's a great question. And so oxygen is medication like everything else. And the way I like to address any medication is it going to make the person feel better? And I like to follow the cues that the patient's given me. People with pulmonary problems, people who have emphysema, COPD, asthma, who have a diagnosis like a cancer that has affected their lungs, often will have oxygen prior to hospice and may have a lot of comfort in having the oxygen applied. If the patient is used to it, comfortable with it, it is fine to provide. The key thing for me is that to make sure that we're not applying the oxygen because we're hearing the noisy breathing. The noisy breathing is part of the dying process, and I would hate to introduce something to make myself feel better if it's not helping the patient. And so if it's provided because we know that it has given relief to the person, then it makes sense, and usually they would have it on anyway. But if it's introduced for symptom relief, it doesn't always line up with actual symptom relief. Things like, and also sometimes people can get a little claustrophobic with things being placed around their nose. The nasal cannula can sometimes be a little bit drying. There are ways around that, but it's definitely things to consider. And so often I'll have patients, family members, especially when I consult in nursing homes, where the patient will be pulling at the nasal cannula, and the family member sitting vigil will be like putting it back and putting it back, and it becomes this almost a little fight, like let's keep this on. And so my encouragement is always, let's take it off. How do they feel? They look comfortable. Fantastic. They're pulling it off because it's uncomfortable. It does nothing to prolong life, but it can sometimes be uncomfortable. And so following the cues that the patient has given us is really important, and making sure that we're introducing a treatment because we think it's giving comfort, as opposed to making us feel better or follow-up protocol, for example.
Okay, great. We've had a few more come in here. So the next one is, do you have any recommendations about how and when to begin the discussion about memorialization and types of burial and cremation? So what the person might want for, after their death?
So I feel strongly that the sooner the better. And in many ways, I feel like the less close you are to death, the more you can make objective, financially sound decisions about how you want the end of your life to go, and your burial and the legacy building to begin, and the memorialization to begin. And so the sooner the better. I think that in people who have ambivalent feelings about death and dying, it's important to frame the conversation as an opportunity to empower them and give them control. And it's also really important to allow for the person to say, time out, this is really intense, and to validate that. And I think as long as the conversation comes from a place of love and a place of wanting to honor them, and they're the center of the universe when it comes to this topic, that it can be a bonding and relationship building event. But it's important to call out that it's uncomfortable. It's important to call out that it's not always easy, even when you feel empowered. I hope that answers the question. And if there's a follow-up on that, please feel free to type it in.
Okay, great. I also wanted to share a story that I heard that relates to this, about a daughter and a father who did it together. And it was this beautiful thing that they planned everything based on what he wanted for months leading up to his death. And then afterwards, she was able to do everything that he wanted and felt like she was really, honoring his memory. So there can be, just like you're saying, I think a bonding there and a way to work together, which is really lovely. Another question has come in from Megan, and she said, can you speak about death with dignity? Do you know how many patients actually use it? And do you have any experience with patients who use this option?
So, and I'm assuming that we mean patients who are taking it upon themselves to have an end of life that is more measured, and physician assistant staff,
Yep.
PAD. Okay, excellent. So my experience with it has been limited. I have had many patients come to my practice with the request of physician assisted death. And I think it's definitely something that should be considered, discussed, enabled where appropriate. And I always think of my patients as examples where this has come up for me, is where in situations where patients had unmet needs. existential needs were unmet, a crisis wasn't being addressed, a physical symptom wasn't being addressed, a social, psychological symptom wasn't being addressed. Once that was addressed, recognized, talked through, with the understanding that we're gonna help and support you to a death with dignity, if you so desire. But once these issues were addressed, the desire to have an assisted death diminishes significantly. And so, in my experience, and again limited, patients came in with the request. Once you dug in a little bit deeper and realized, like, oh, you have excruciating pain, and of course you want death will be a relief from it. Let's address the pain. Once the pain was addressed, that went away. Once the other folks had existential crises that needed support and needed guidance, and once those were addressed, they no longer desired death. And I can think of a patient who lived for another 6 months and was really grateful that we had that initial conversation. But certainly, if the process itself is one where we want to make sure that people understand what is happening, that again their symptoms are relieved, and that we engage in a conversation about why it is that this is needed and wanted without judgment, right? We need to allow more space for people to really have control over their life and control over their death. So I think that that's really important, but often we can be in a state where we're not thinking about what brought them to that decision. And sometimes, not every time, it's because there's an unmet need that is fixable and that is addressable. And so we want to make sure that that gets addressed, and then if not, then move to PAD where appropriate. I have never engaged in it, but have many colleagues, have had colleagues assist, and it is just another way in which we can care for people, and a valid way that we can care for people. So yeah. Any other questions?
Let's see here. Yeah, we have a few more come in, and I'm just going to add a quick note to that same question. I think that there's data on the percentages of people who actually use the drug, and I think it's more exactly what you're saying, kind of about a sense of control, of just having it in their home, so they know that they have this resource if available. But I think a lot of the times it's not used, which kind of exactly speaks to your point about control. The next question is, can you talk a little bit about delirium at the end of life? I had a friend whose husband passed away and said some really awful things to her that she is now carrying with her, and I'm wondering if that's a normal thing that happens.
Yeah. Yeah, and thank you for bringing that up. That is one of the things that can happen at end of life, delirium, and hallucinations can also happen, and that can be a little bit distressing. It is really important to know that delirium can happen, and it can be where somebody is having a pleasant, however outbursty interaction with the stimulus that is causing their delirium, but sometimes it can be pretty intense and negative. The importance, so I wish your friend can make peace with the fact that this is not the loved one's feeling about her, but rather the delirium talking. It is very common. Often we'll see in people who have delirium and overcome it, and not at end of life, but similar delirium type phenomenons through severe illness, where they will overcome the delirium and get back to a more to their baseline, we'll say, to their usual state of being, and have no idea that that interaction occurred, feel complete shame and disbelief that the negative thoughts or whatever negative things were said, the words that came out of their mouth were said, and also that they don't remember it. And so I hope your friend knows and understands that this is part of the dying process, and that's why it's so important to keep a real open mind, because and think of it as part of life, but not the thing that they should take with them. You know, that this isn't your husband. Your husband was all the other things over the 20, 30, 50 years that you were together. And that's a really hard thing to come to peace with, because, you know, we remember good things, but we also remember the bad things. And that's where I think that the hospice team support is really important, because they can really help you navigate that. And for you to be able to speak to that, wow, that really sucked. That wasn't okay. That doesn't feel right. I'm holding that, and it's part of my grief, but also it's not letting me think of all the other times that we were together. And so I hope your friend, it sounds like she's finding solace in supporting you, but yes, sometimes things that are completely unlike the person can come out, and this is very normal in the dying process. We can help with medications to help ease that at the end of life, and a hospice team can really support in giving medications to ease that stress for the patient. But I think it's really important to remember that, well, that may be a really tough event. It really doesn't define your relationship, and it's has absolutely nothing to do with the way your partner or your loved one feels or felt about you.
Thanks. Okay. Let's see. The next one is kind of related to your end of your talking point there about drugs at end of life. The person asked, can you talk about morphine and how it helps someone?
Yes, absolutely. And thank you for bringing this up. I thought about it for a while. Do I want to talk about medications? And wanted to really let the group lead with that one, because medications at end of life can be such a polarizing topic. And so I'm glad that we're discussing it. So the use of medications at end of life can help with relief of suffering. It is possible that while people are manifesting all these symptoms that I described that are normal to death, there are other symptoms that can come up from the chronic illness that is leading to their death, or their own particular death process can be uncomfortable. Morphine and symptom management medications are there to relieve suffering. The way that morphine works is that it's a pain medication, so it can help with things like muscle spasm from not having a lot of water intake at end of life. Your muscles can spasm sometimes when there is dehydration, which is natural, but it can also be uncomfortable. Pain from cancer, pain from an orthopedic injury, pain, your chronic arthritis pain from laying down when you were pretty active before. All these pains can be relieved with morphine. Morphine also has an added effect, which is it can also help with the sensation of shortness of breath. Many people, because of the disease process leading to the end of their life, can experience shortness of breath at end of life. And morphine works in the brain in a way that lets the brain realize that this low oxygen level, or the way that I'm breathing is okay. And so let's relax. Let's allow my breathing to continue as is. Let's ease it. And it really can be helpful in relaxing the person and taking all the adrenaline down a minute. And what we notice is when we take anxiety, when we take pain, when we take shortness of breath out of the picture, patients live longer, more comfortably. And so there is this idea that you're giving something that we know people overdose on and stop breathing. To the person that's having problems breathing, the whole correlation and causality dilemma comes up. But we know that if we're giving the right dose of medication to someone who is having suffering, their adrenaline eases and they're able to be in a more steady state and can live longer. And so many times I'll give someone a small dose of morphine and immediately their breathing eases, their blood pressure normalizes, and they are able to engage in conversation or sleep, and usually have a prolonged life. And this is true of hospice in general, but specifically symptom management medications can really help people be comfortable for longer. And so, and culturally, we also know that there's this idea that, the minute she got morphine, she died, or the minute they got this medication, they died. Correlation and causality again. They were dying. You gave them medication that relieved their suffering and allowed them to die at peace. And that's how I like to talk through that with people. So again, it has a direct pain relieving effect, but it also has an effect of relieving the sensation of shortness of breath, which can then be anxiolytic. It can relax the anxiety and the stress and help you be more relaxed. Other questions?
Yeah, we've got another one that's a little bit about what you talked about earlier, but maybe we can go into a little more detail. She said, are there any specific signs to look for during the final days of life that may suggest the end is near?
Yeah, absolutely. So some of the things that you'll notice are breathing pattern changes. That is really a big one that we notice. Some people tend to run cold hands. If you touch me, I will freeze you because my hands run really cold. But if there's a change in the temperature significantly from what your fingertips feel like usually to the time you're evaluating the person, that's another really big one. The breathing pattern can change and you can feel that noisy breathing. And also the skin changes, what we call mottling. And so just blood not circulating in the way that it usually does. And so with gravity, it tends to go to the dependent areas, the areas where the body touches the bed, and you might notice some darkening color or purplish mottling color as well. And so look for breathing changes, the pattern of breathing, pauses in breathing, and the noisy breathing, the changes in color and the changes in temperature. And again, all these are very natural. You're not doing anything wrong. This is just what you can expect.
We had another question come in along these same lines, and she asked, is a hospice organization required to educate patients and their families on these types of bodily clinical changes to watch out for as someone nears active dying?
There is a lot of education that happens with hospice. There's also a lot of reassurance that the team wants to do. I think that there is a balance of wanting to make sure that you can be there and just love on your loved one rather than be sort of a provider of care. And so the education happens on a very specific family-centered way. And so I wouldn't expect a hospice team to speak to you about symptoms the way that I would expect them to speak to another family. Some people love the details. They want to know how many respirations per minute should I be looking out for, or more specific objective signs and symptoms. And some people just want to know, is she okay? What do I need to do? What do I need to look out for? What am I looking for? And so I think mandated or there's always education that happens, but providers are very cognizant of the fact that they want families to be families and not be the hospice nurse for their family member, even though there will be times where they will be given medication, etc. And at the same time, really cater to the need, which is, for some people, I really want to know those little details. When in doubt, ask. If it's important to you to know specific things about the dying process, just ask the question. If they don't have the answer immediately at hand, they can refer you to resources, whether online or in their own literature. It doesn't hurt to ask, ever. And I think that that's the cool thing about hospice teams, that communication is kind of their jam. And so asking questions is something that they're expected to do and to answer. So definitely use them as a resource. I hope that answered the question.
Yeah, and that person, if you want to shoot us a little note, just in case if we need to add anything. And someone else checked in here with a hospice related question, and they said, often with the hospice that is used at one of my workplaces, they don't worry about patients that have respirations over 30 per minute. I think the patient is working too hard. Do you have an opinion on that?
I think that different hospices probably have different protocols in place. I think that respirations 25, 35 are commonly thresholds that are used in order to help and medicate the person. I think for me, my opinion is usually I like giving parameters for teams, but I think really following the other signs and symptoms of distress. If we feel like somebody's in distress, then we definitely want to relieve suffering, and also that breathing will change and will become shallow and will become fast. And so the question is, if you feel like this is distressing, then address it. If you feel like this is a natural dying process, then obviously it's hard for us to see, but certainly very natural. And again, the majority of times with all these changes, the patient doesn't really feel it. We feel it. I also believe that if in your heart of hearts there's a feeling like this doesn't feel right, a low dose medication, appropriately dosed, will not hurt. And I always tend to err on the side of following my gut and listening to the family if they feel that there's a symptom there. But really reasonable for a family member to be like, ooh, they don't look comfortable, should we medicate? And then there can be a conversation there.
We had another one come in about after a death. They said, is there any hard requirement that someone call a funeral home directly after a person dies?
A hard requirement in terms of timing, or?
Yeah, I think so. Most of us haven't really done this,
Yeah.
we don't know what the
Yeah.
protocol is. So I think the standard is, we just get the body removed, and most of us don't realize that it's actually safe to be with the person.
Yep. Yeah. And that's really important. Certainly, we want to be mindful that a dead body will, the natural process of decomposition will happen, but there's ample time for that to happen. Certainly people with open wounds and things of that nature, we want to be mindful of, but you have time to sit with the body. There is no timeline of like you need to call them within like 30 minutes of death. Certainly if in the Jewish and Muslim communities, there may be some timeline that needs to be met in order for the religious requirements to be met. Certainly we want to make sure that that is followed, but a requirement with a funeral home that you have agreed on, that's not the case. You're not going to remain with the body for days, because again, that you want to be mindful of the natural decomposition, but you can sit with the body. We actually encourage that, if appropriate, having sort of a viewing is reasonable. Prepping the body, getting the blankets on them, You know, sometimes family members will brush the hair and give them a teddy bear, put on the shirt that they loved. All these things are really reasonable to do if it feels natural to you, but also just sitting with the loved one is um, welcome, because what it does, especially in a society where death is so medicalized, um, even if you're a baby boomer, a Gen Xer, or a Gen Zer, the reality is that the American medical system, just the way we are and the way we've addressed death, it's not natural, even though it totally is, right? And so keep making the time to just be in a space of, I am visually seeing this person who is no longer alive, and I am processing my emotions in real time with my community where appropriate, is really, really important. So yeah.
Okay, great. Let's see. Oh, here's one final one here. This is just kind of a mention, I think, on the same topic. Home funeral agencies can help a family keep the body at home for the desired length of time using dry ice. They have a lot of experience working with what a particular family may want. Yeah, that's a great point about the dry ice.
Yeah.
Yep.
Good point. And good conversations had ahead of time are also good. So you're not, so you can really be in sort of the grieving process and not having to do a lot of housekeeping. And so if you know, my siblings in Vegas and they want to drive down, or they're flying down, and it's so important that they're with us, then it's a great conversation to have with a funeral home and say, listen, can you just help us keep mom in the home until my sister gets here? Great conversation to have ahead of time.
Yeah, and Kim put in a little note that said the National Home Funeral Alliance is also a great resource. So we will make a note of that in the email we send out to everybody. I think we are just at time here. So if no other short questions are coming in, I think we're set. Thanks everyone so much for being here. Thank you, Claritza, for hosting this. Lovely to have you. I hope everyone has a great
Thank you.
weekend. Happy Father's Day to everybody who may be missing somebody or has someone around, father figure, whatever it is. Thanks again for being with us, everyone.
Thank you, everybody. Take care.